to the February 16th, 2021 COVID-19 clinical rounds after discharge. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who have collaborated on these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Streminger and his team for the peer-to-peer learning platform we use for the rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS, Tuesdays are critical care, and Thursdays are emergency department rounds. This coming Thursday's emergency department rounds will be focused on COVID-19, the emergency department, and telemedicine. Our HHS Emerging Outpatient Therapeutics series are on Wednesdays. Dr. Streminger, I'm going to turn it over to you now, please. Thank you.
Thank you, Rick, and welcome everyone. Thanks for taking time out of your busy days to join us. And in particular, thanks to Alba and Aaron for joining us to share their experience. Just going to go over a few housekeeping items. We really want your questions, so please share those with us in the Q&A feature along the bottom of the Zoom toolbar. If you have any technical or logistic issues, please put those in the chat, also along the bottom of the Zoom toolbar, and we'll try to help you out. We are recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. Today's presentations will be made available through the Clinical Rounds website, and the recording will also be made available there. We'll share a link in the chat to the website, and the recording should be up within a day or two, along with the PowerPoints. We are offering CME and continuing education credits through the University of New Mexico, where Project ECHO is based. We'll share a link in the chat to the CME survey about 15 minutes before the end of today's session. You'll have 48 hours to complete that survey. We really appreciate your feedback. It's what helps guide us in improving these sessions and gives us ideas for upcoming topics, et cetera. And you'll be able to get instant CME and CE. Just a reminder that these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please let's keep them apolitical and non-commercial. Thanks for that. Just a note about data use. The data you share with us when you register, the polling responses, the Q&A, et cetera, we keep confidential, and the data we share with Rick and Asper is all de-identified. Rick mentioned that NETEC, the National Emerging Special Pathogens Training and Education Center, is a partner in this initiative. They have their own terrific webinar series. The next program will be a week from Wednesday, so February 24th. It'll be on saliva testing, focusing on novel strategies for screening. Rick also mentioned that there's a mini series focused on outpatient therapeutics that's part of this initiative, currently focused on monoclonal antibodies, and tomorrow's session will include examples from California, Texas, and Utah. So please, anyone interested in how monoclonal antibody delivery is rolling out across the US, please join us tomorrow. Also, the American Association of American Medical Colleges is a partner in these rounds. They have a great clinical guidance repository that they've been updating since almost since the beginning of the pandemic, going back to last March or so. So please check that out, great resources. Rick, back to you for the crowdsourcing question for today.
Thanks, Bruce. I believe this is since March 24th last year, this is our 121st rounds. And I think the last numbers I saw were over 40,000 participants during rounds since the beginning. I'm not nearly as worried about the numbers as I am how much we've all learned from each other. But as we think about moving forward with rounds, we want this to be your rounds. This is not just a bunch of people at in leadership positions trying to figure out what we're going to do next. Really need your input on this. For the next 3 months, what topics are most important for us to address during our COVID-19 clinical rounds? Be great to see responses in the chat. I could, Bruce, I'm thinking about like the topics I'm thinking about talking about, but I don't want to bias the input from our participants. So I'm not going to say a word. It would be really helpful to see your thoughts on this. Let's see. With that, there's Harry. Goodness, and Tom Laurie. Oh gosh, Harry's in the deep cold of Texas right now. If our panelists could please take themselves off mute and introduce yourselves, that would be great. And I'll start with Harry.
Hi, my name is Harry Seibold. I'm an emergency and EMS physician from Helena, Montana, past state EMS medical director, and currently on a long-term COVID assignment down in surprisingly snowy and cold Texas, where we had no power for the last 2 days.
Great. And Tom, I see you joined us.
Good morning. I'm Tom Laurie. I'm a ICU doc for 16 or 17 years at Sharp Memorial in San Diego. I'm the chief medical officer for the past year, doing all COVID all the time, and happy to be here.
Great, and thanks for being here. Appreciate that. Let's see. With that, I'm going to turn this over to our first speaker, Dr. Aaron Bonnell, attending physician and assistant professor. He's the director of rehabilitation consults, UW Medicine, University of Washington Medicine, the Department of Rehabilitation Medicine. And anybody who's the director for rehabilitation consults, always glad to have you on board. So with that, Aaron, please.
You guys, let me just share my screen here. All right, can you see that? Okay, we good? All right. So yeah, just a little bit about my background. I work at Harborview Medical Center, and my research and clinical interests have been centered around recovery after the ICU and ICU survivorship, and work with Terry Huff on some of the neuromuscular outcomes of those patients and long-term outcomes. And I think that's where my interest segues into some of the post-COVID work that has been done. In the beginning of the pandemic in April and May, we all saw that these patients were getting very sick. And our team thought, we're really going to have to deal with a lot of the post-ICU survivorship in these patients, and decided to form a post-COVID rehabilitation and recovery clinic centered on these patients. And we really initially envisioned that clearly as just the impacts of critical illness and on the neuromuscular system, the cognition, the endurance, and the mental health complaints that, post critical care survivors experience, in the PIC syndrome and ICU card weakness. That has shifted over time. The clinic has evolved with the pandemic, and now we're looking really more also at patients who are never in the ICU, never in the hospital, and really are suffering from direct effects of the virus itself. And to give you a little idea, our patient volumes in the summer were kind of 1 to 3 new patients per week. We probably weren't capturing everybody that was in our hospital system. But by fall, we were starting to see kind of 4 to 5. And then with the explosion in the numbers over the winter, I think last week we had 50 new consults, and the numbers have been going up very quickly. Our initial plan was to really screen all patients in the domains of physical function, their endurance, their cognition, and their mental health, and then to build a therapy and rehabilitation regimen and address each of those individual needs, whether that was neuropsychiatric testing or rehabilitation psychology for some of the, adapting to disability and anxiety and depression that we were seeing. So we're going to build a comprehensive rehabilitation approach for each of those patients. And then for our inpatients, we were providing educational materials on recovery. This was best guess materials because we didn't know exactly, and it was based on prior work with ARDS and ICU survivorship. And then we gave them a starting home exercise program and a progression ladder for that progression of exercise. And then all of our inpatients were seen in the post-COVID ICU rehab clinic after 1 week. We've now opened that up to anybody who's had a diagnosis of COVID or a suspected diagnosis of COVID, that they're welcome to be seen in our clinic. So this was kind of our initial idea. We've now opened that up to outpatients and throughout our community. And this was our elaborate, throughput model from hospital to the outpatient screening. We really wanted to see everybody that was in the hospital because, sometimes there really aren't deficits identified in the hospital, but, walking 50 feet down a linoleum floor is not the same as, walking up 2 flights of steps at home, or actually trying to return to your job, or, having to, you might want to return to activities that you loved, like jogging, and now you can't do that. So we really wanted to screen everybody, and there may be mental health issues or cognitive issues that are showing up. And I think that was the right approach, because we did identify that a lot of these people that looked okay in the hospital really found that they couldn't return to their high-level job at Microsoft with the same alacrity, because they're feeling a lot of brain fog and a lot of issues there. I think the arm that we've added now, as I said before, is that it's not just these hospitalized patients, it's also the outpatients that are experiencing many of those same deficits. I think the other issue that's come up is that many of these patients have additional medical issues that need workup. So I think, although I was talking earlier about some of the POTS that patients are seeing, or some of the autonomic instability, the other issues that we're seeing are a lot of anxiety and depression that are very kind of beyond the resources for our behavioral health in our clinic, and really need more psychiatric intervention. We're seeing patients that need cardiac workups and pulmonary workups, and and autoimmune workups. And so I think the medical component is more complicated than we maybe initially suspected. Our clinic was set up initially and is currently running primarily on a telemedicine model, where the doctor sees the patient via telemedicine. Once the patient is COVID negative, they can be brought into the clinic, or once they've cleared they're essentially cleared from our infectious control standpoint. We have both telemedicine and in-person PT, OT, and speech therapy. Each of those geared towards their own domains. And then we have an additional multidisciplinary team. And this is kind of how our team works for each of these domains. So we have, I think some of the important ones have been vocational rehabilitation, some of the neuropsychiatric testing for patients that have had the issues with cognition and return to work. And then, therapeutic recreation has been really helpful for establishing transportation and helping patients to navigate the community. I think initially we decided to set up the clinic as a consultation with subspecialties based on their own referral criteria. So we reached out to cardiology, pulmonology, neurology, and each of those having given us an idea of what kind of patients needed to be referred to them, because we were often the first point of contact for some of these patients coming from the community. I think that will need to transition. Here's an example of the screening throughput that we initially decided to do in the telemedicine visits. I think this was maybe a little bit robust and aggressive, just because I was thinking more from a research standpoint, and my clinicians were not as happy with me as as I should have been. So we're working now to change how we obtain the screening measures and really free up the clinical visits a little bit with kind of, and I'll talk about this in a second, but essentially we really want to screen in the areas of physical function, endurance. Cognition was important, both self-reported and objective measures of cognition. Depression with secondary measures of PHQ-4 if they test positive, PHQ-9 and GAD-7, and then especially for RCU survivors, the BC-PTSD-5. I think now that we're changing the model, so we really, I think we initially envisioned this primarily as a rehabilitation clinic. With our colleagues in internal medicine, we're really looking to make this more of a collaborative, multidisciplinary center model, where the patient is seen both by us and internal medicine. And there's a couple of goals in that. One is that a lot of these patients are being seen by specialist after specialist after specialist after specialist. And the specialist may or may not have prior experience or expertise with post-COVID patients. And that results in, I think, more medical workup than is probably necessary, but also a lot of patients feeling that there's nobody who understands what is going on with them and nobody who recognizes the validity of that. I think there are some providers who, if they've not seen something before, will discount the patient's reported history of it. And I think that's leading to over-medicalization, over-utilization of resources, and patient dissatisfaction with care overall in the system. So I think if we can build that into a center model where a truly experienced clinician is determining what specialties are needed and what workup is needed, and the rehabilitation and other functional needs are addressed, that's going to be the best for the patient. And that way they're not having to be shipped around to, like some of these patients, 6 or 7 specialists and multiple doctors. We've also obtained some UW funds to really build in a patient-reported outcome model through the EMR, which is more succinct and easier for both the patients and our providers. So nobody's going to yell at me now. This really, we're doing the Promise 29 because it incorporates a lot of the areas that we were looking at before in terms of physical function, quality of life, anxiety, depression, and pain. And then adding in Promise dyspnea and cognition short forms, the HAC, which looks at some of your function for basic ADLs, the PHQ-4 and PTSD. The goal in this is to have longitudinal data on the recoveries and then the phenotype patients. So this is a really brief introduction to what we're doing, but hopefully of benefit. So, thank you.
Aaron, that was a quick overview of what I think I understand is a extraordinarily complex undertaking. So thanks. I mean,
yeah, I'm giving you just kind of the surface level view of it, but
yeah, I only gave you 10 minutes. I get it. So Aaron, okay, so a couple questions. If you take your slides down, couple questions before I ask Tom and Harry if they've got any questions. One is, and actually Bruce Strominger texted me this one. I think it's a really important one. It'd be good to know how you're coordinating the multiple telemedicine consults. As you mentioned, I mean, there are multiple players involved with this. So How in the world do you do that? Do you do a Hollywood Squares like this, or are you doing individual? How is that working?
Yeah, so within our clinic, we have a huddle that is, we're not doing it in person, but it's by Zoom meeting. And I think we have some advantages because that clinic was already built for multidisciplinary care of complicated patients, so spinal cord injury, stroke, traumatic brain injury, post-ICU survivors, and some of our complicated neuromuscular cases. So there was already experience with huddling between, rehab psychology, neuropsychiatric testing, speech therapy, PTOT, and how to formulate recovery. I think what's the added difficulty has been trying to coordinate between multiple other specialties. So pulmonary medicine, cardiology, et cetera. And what we did was identify point people and really communicate directly with them. But that is part of why we're trying to shift to this center model, because of that difficulty with communicating, each individual provider. So I think we really need a different model to address the complexity of these patients.
Thanks, Aaron. One from a question from one of our participants. Have you incorporated the post-COVID functional status score into your evaluation? And if so, what objective measures scale do you use?
Yeah, we have not incorporated that in. Part of that is because of some of the research that was started in the spring. We're looking at trying to continue some of the measures that we were already obtaining and building into those studies that are ongoing. So, but I think that's a great measure to have. The other issue is we're using Epic, and we wanted to use measures that were built into Epic already and readily available. So I think we were a little limited in those.
Thanks. Let's see, I'll turn this over. Tom, any question or comment before I move to Harry?
No, thank you.
Harry, yes.
So, Dr. Bonnell, I really enjoyed this. A lot of thoughts have gone through my head as you've been speaking, and especially with your statement about avoiding overutilization of resources. It seems like that's a significant challenge as we're still struggling with the disease, and now we're also struggling with this unknown of all of these post-COVID syndromes, some with people that had very mild cases of COVID. I've had experience with a number of people including some of our physicians here, that had mild cases of COVID and then suddenly some weeks or months later had unexplained tachycardia, and how do you avoid getting an echo, getting an EKG, getting a consult, and things like POTS, which is a difficult diagnosis and sometimes a diagnosis of exclusion on the best days. I'm really interested in kind of how you've worked your way through that problem list to get to a streamlined workup of the patients that you're seeing for their post-COVID symptoms.
Yeah, and I don't think we're truthfully there yet, which is part of why we're trying to transition to that model. A lot of our patients have already been through many of those workups within the UW system and then finally find their way to our clinic. So they've already seen 4 or 5 specialists by the time they've seen us. And that's part of why we wanted to really build into the UW system a center for these patients, which avoids, that kind of doctor to doctor approach. I think in our own clinic for patients that are newly seen, what we've done is, reach out to point people within each of the departments that are interested in each of those individual conditions. So for example, our neurologists who are in the POTS clinics, we've really asked them, like, what is the appropriate workup? What patients should be seen by you? What can we preload before they see you? What workup would you like to have done? And then, and what patients do we not need that? And I think our goal is with that center model to build for each of the patients and each of the presentations, what would be the right approach. So, and that would be based on consensus, and then revise as we learn more and as time goes on. And
Hey.
Alba might have something to say about
Yeah, Harry?
the pods.
And just a brief follow-up question. So are you building this as a center of excellence within the UW system, or are you expecting to be able to gather referrals from outside your system and bring them in so that they have kind of a one-stop shop kind of system?
Yeah, it will start within the UW system as a center of excellence, but then we are also seeing a lot of patients throughout Washington and some through the WWAMI network as well. So, and eventually the goal would be to provide support to the communities, and provide them their own centers and own appoint people.
Thanks. I'm eager to get to Dr. Zola's presentation, but I got like two questions. The managing payment, how's that working? And then I'll ask the second one, and then we'll go to Alba.
So for the telemedicine visits, we've been fortunate to just to be able to bill as a telemedicine visit with the changes in the rules. The challenge there is that we are serving multiple states and we're not able to see patients out of state with telemedicine. So there we've either been saying to patients that they have to come see us, or trying to find people in their own states that are able to see and consulting with those providers directly.
Well, there's a reason to break down that barrier. Traveling versus a telemedicine. Wow. Yeah, I get it.
It's challenging because if they, like some of our patients in Oregon, if they drive 10 miles and see us by telephone in Longview, Washington, they can see us. But then if they're 10 miles away in Portland, then they can't. So we may have to think about that as a nation.
So, Aaron, and I think I was going to talk about this too, but this whole center concept, realizing I'm a little bit of a danger zone here because there's so many disciplines that are represented as participants on the rounds. But in your observations to date, your own experience, who's best positioned to actually lead a center like that? The kinds of discipline, or is it like, you got to have like 2 clinical leaders because you got to get the side, or your thoughts on that, realizing nobody's like putting a stake in the ground on this, and we're not trying to like build empires, but who's best positioned to do this right now?
Yeah, of course I have my own bias, but
well, really?
I think there's two big categories of what these patients need. One is the medical workup and the medical evaluation, and then the other is functional, symptom management and return to work, cognition, return to basically life. And I think this, in my concept, the center would be run in tandem between someone who's able to manage that functional side and the rehabilitation side, and then someone who's able to manage the recovery side, so the medical recovery and the medical evaluation and workup. So I would imagine an internal medicine or pulmonary medicine doctor would be one of the key partners, and then the second partner would be a rehabilitation specialist. So. Yeah,
thanks. I appreciate. Yeah, I realize it. Yeah, it wasn't a trick question, but I know it was a particularly an easy one to answer. There's another question in the chat I didn't get to, but I really eager to get to Alba's presentation. So with that, Echo, if you could put up her slides. Dr. Alba Zola, assistant professor and co-director of the PMR PACT Clinic and the Department of Physical Medicine and Rehabilitation at Johns Hopkins School of Medicine. So Alba, welcome, and I'm really eager to hear your presentation.
Thank you, and thank you so much for having me today. It's been really great just listening into the previous presentation and how, we're many, many miles apart, but we're facing the similar, seeing similar observations and facing similar challenges in terms of trying to provide the care that this patient population needs. So I'm going to talk a little bit about our efforts to create a multidisciplinary outpatient survivorship program for COVID patients that was started in April of 2020. Our group from the PM&R side includes Dr. Soo-Young Kim, Dr. Chae Shung, myself, a physical therapist, Lori Fitz, and Anna Agranovich from neuropsychology and rehab psychology. We are partnered very closely with the co-directors from the pulmonary side. And typically we have joint meetings together of our whole PM&R and pulmonary team to discuss patients. And we've been fortunate to be able to pull resources from the Department of Pulmonary in terms of case manager and nursing that are able to help us kind of follow up with patient care and needs. So next slide. We knew early on that the numbers were going to be very large and the number of patients that are going to be requiring ICU stay was going to be significant. And given the experience on post-intensive care syndrome, in particular, also the experience of our institution, we knew that this influx of impaired physical function, mental health, and cognitive deficits were going to be seen in this patient population. And we know that this tends to have an increased use of healthcare resources, mainly readmissions. We then started also noticing an increase in referrals and reports of lingering symptoms of patients that were not hospitalized. Next slide. And we know from reports that there are significant symptoms that can be quite impairing to reincorporating to life in patients that had COVID. 3 months, 6-month follow-up, they continue to report significant fatigue, orthostatic tachycardia, intolerance of standing position, muscle, joint aches, often some GI symptoms or return of IBS or flaring up of IBS symptoms. And we've seen kind of an overall fluctuation course over time. So we base mostly like Dr. Bromwell was also commenting on this known post-intensive care syndrome, right? We knew that this was coming and we wanted to establish a clinic that would encompass, all the needs, including mental health, cognitive impairment, as well as functional impairment and the medical complications. So it was kind of a natural joining forces of the PM&R department, as well as the pulmonary and critical care department. And our goal was to provide a continuum of care to address the unique needs of COVID survivors. And we wanted to establish a multi-D resource focus clinic for the recovery and the support that the patients would need. And to the unknown, to support also the recovery of the potential unknown long-term complications. We wanted to create a way that was streamlined, that would carry the patient from the inpatient to discharge and follow up in the outpatient setting. And there's been a lot of effort from our institution as well on intensive rehab while the patients are in-house. And that's that way we, based on those findings during their inpatient stay, we identify them and then create a referral program with our case managers in the inpatient side to refer patients to us based on an algorithm. You can go to the next slide. I forgot. Yeah, and the next one too. I've been talking about this past 2 slides. Sorry about that. And we also wanted to understand the natural history of the disease. So we can move on to the next slide. So basically it's an integration of the inpatient team, mainly the COVIDist or internal medicine COVID providers and case managers in the COVID units. And then we would stratify them in terms of needs for home care, home remote patient monitoring. And based on those needs at discharge, they would get referred to either pulmonary PACT so just the pulmonary part of it, or if they did have some rehabilitative needs, then they would also get referred to pulmonary and PM&R packed clinic. This initiated as a telemedicine service, right? So most of our visits were all telemedicine and telerehab. However, in the past 3 months, we've been able to start inpatient visits where we have a pulmonary provider and a PM&R provider together that's able to evaluate the patients, which has been really a great addition to our team. Then once we evaluate them, we then refer to our network of specialists. So we've identified key specialists within the psychiatry team, within neurology, cardiology, infectious disease, nephrology, rheumatology. The list here is very small, but it keeps expanding as we keep seeing new findings post-COVID. Dermatology as well, hematology. And then we close the loop by communicating with the primary care provider. Although I must admit that many times we end up being the primary care providers in terms of coordinating, complex care. And our PAC clinic really embodies the tripartite mission of Hopkins. We want to propel research, continue to provide strong teaching in our clinics, as well as provide excellence of care. From April to today, we have served more than 400 patients. About 70% of these patients were admitted to the ICU. And there's been a wide spectrum of ages, but the main age has been 54 years old is the median age. You can go to the next slide. Yeah. And click again. Thank you. It's interesting to note that we have seen just like many other centers reported an increased population of Black African-American patients, as well as a significant representation of Hispanic and Latino. So we've worked really hard to provide equity of services, including accessing some governmental funds in order to be able to provide care for patients that are uninsured. And we can go to the next slide. We established our model, and we're very excited to share our current model, and we have with other institutions in the nation as well as internationally, and we continue to be in touch with them kind of in order to learn more from each other's experience. Next slide. So to summarize, the physical medicine and rehabilitation department component of the PACT services include physiatry or PM&R PACT, specific POTS PACT clinic that's led by Dr. Tae Chung, one of our assistant professors in the Department of PM&R. And we have our PACT OT, PT, and SLP. That should be SLP instead of SLT. And these group of therapists have been involved in the inpatient care as well as outpatient. So initially, when the pandemic started, most of our outpatient therapists were recruited to provide services in the hospital. And this group of therapists has continued to have interest in this patient population and now are helping us provide telemedicine services and rehab services for them as our clinic grows. And we also have PAC Psychology, which is led by Anna Agranovich from our neuropsychology side of PM&R. Next slide. So our research aspirations are to define the spectrum of pulmonary complications in long COVID, physiologic correlates and risk factors that make patients more likely to have this presentation. We also wanted to create an infrastructure for therapeutic trials and competitive grant applications, to provide a resource for all the emerging questions that we have, including creating a biorepository that would help as well answer some of the questions. We also wanted to interrogate the economics of care delivery and basically, does this care model can be self-supported? When you think about the decrease or potential decrease of rehospitalizations, we actually started looking at those numbers as we've been putting our budget proposal together for our dean, asking for more support. And we have seen a modest, but definitely present this decrease on the need for rehospitalization. And it's pretty encouraging. Next slide. So if you have any more, you can browse to our website, hopkinsmedicine.org/coronavirus/pact. And if you have any other questions, please feel free to email us at pact@jhmi.edu or contact my co-director, Sue Kim, at skim453@jh.edu. And you can also refer to our publication in the American Journal of Medicine regarding our team.
Thank you very much for your presentation. Two questions. First one, and Aaron talked about it too a little bit. The psychology, the mental health, the cognitive, all those pieces.
Mm-hmm.
A lot there. And the fatigue piece. I mean, you put the fatigue one up, as I recall on your chart, they were like highest up there. So has your center there been able to like sort through, okay, these are that's not the right word. Are these patients with exclusively mental health challenges, as in depression, anxiety, et cetera, versus as a consequence of COVID, versus cognitive disorders, the fatigue piece, all the other stuff? Or is it still so kind of all murky, bundled up that you're just keeping them all within the system without just like saying, okay, it's time to go over to psychology, psychiatry, and yeah, I think that's where you're better placed? Or is it still totally a mess right now?
I think the still totally a mess would be one way.
Okay.
The reason is that, the way that we think about our clinic is that we want to enable patients to get back to life, right? So our main focus is, what are the symptoms that are most impairing? Where do we need to get you to so that you can reincorporate to life? Is there a medical intervention? Is there, techniques that an SLP can help with memory, for example? Or, do you have a very demanding, higher cognitive level, job that requires a full cognitive evaluation by neuropsychology in order to, assess if you're fit to go back, right? And
Right.
So it's very specific to each patient.
It was like just listening to a number of presenters, like it's been very difficult to figure out, and I think it's because it's probably not figured out yet, whether or not you can truly say this is, depression because he had challenges with it and not related. Unable to figure that out yet. So I appreciate that. One other question, and then I'm going to do the polls, and then I'll get back to our panelists and back to each of you for last word. But you've seen 400 patients. When I take a look at the numbers that are reported, even in the news, just like you are, and I think about just the sheer numbers, biggest catastrophe in a century from a healthcare perspective. What are your thoughts about scaling up? I guess my sort of like immediate reaction is, okay, this is not like the STD clinic or the AIDS clinic or the TBI clinic. It can't be. I mean, it can't be that much. It can't, that won't be enough. So what are your thoughts about scaling to where we can like really support people?
Yeah, I mean, that's the problem that we face right now is that, you know, initially we started very early on, and we had a lot of people that were in the outpatient, that were out of work, basically, from research projects that were put on hold due to the pandemic to things like that. So we actually are losing resources as more patients are needing our services. So we're on the, right now we're asking for support from our institution, and as well as working on grants to support us and provide more assistance in order to provide and meet the needs, right? So it's a complex situation, but definitely under recognized, I think, at this point, the magnitude of the needs of this patient population, you know, and I feel like I'm talking to the choir, you know, this particular group. The reality is that, you know, these patients clearly need assistance in order to reincorporate to life, and they also have real medical issues too. So it's definitely a challenge to meet the needs at this point. Yeah.
Thanks. You did a great job of verifying what I think I saw too. I think I was talking with Bruce or with all of you in the green room, as it were. It's like our third or fourth rounds on the long-term care issues, and at least I'm committed to make sure they don't disappear from this forum for sure. So let's go to the polls. There's I think 6 or 7 questions. So if you could like kind of like divert your attention from the email or whatever and like get on the polls, that'd be really helpful. Okay, so I have experienced the following barriers in getting my patients, COVID patients, long-term care.
I wanted to chime in regarding the referral issue. We also have restricted our services to our institution, but we do receive referrals from other states, and they actually have, people have flown in to be seen in our in-person clinic. But yeah, it's definitely a limitation with the telemedicine.
Oh my goodness, yeah. I appreciate you're both highlighting that. It's not a small issue.
Yeah, the volumes are really challenging, and we're in danger of washing out our entire clinic with just COVID, and we have to still serve spinal cord injury and stroke and TBI. So we're really, we started with 2 providers, and now we're at 6 doctors, and we could probably use 2 or 3 more.
Yeah, and both of you talked about the telemedicine piece, and to me, you know, how to scale up quickly, because there's just not enough of you. I mean, can you do more with telemedicine? And clearly you can if you have the like ability to do it. So I get it. All right, let's stop there. 51% have voted. Thanks, everyone. I'll let everybody take a look at the responses here. All right, thanks very much. Next. One or more healthcare facilities in our region are seeing patients in COVID-19 follow-up clinics, are planning COVID-19 follow-up clinics, are not planning to establish COVID-19 follow-up clinics, don't know. And one thing to my PMR colleagues here, one thing that would be great if you're like, whatever societies came up with a uniform name for these things, whatever they are, that would help a lot, especially when you think about, the telemedicine and so forth, so on. That would actually help a lot. It's not something I'm going to do, but
Yeah, I've been on a few calls of that. It's been challenging with the NIH and with AAPMR. So.
All right, let's stop there. 44% have voted. It's a pretty diverse response there. That not planning to establish COVID-19 follow-up clinics, looks like Alvin and Aaron, you have, there's a lot of opportunity for your institutions apparently. So, next. Okay, now the wording in this one's important. There's two pieces. The most common long-term consequence, okay, most common, and then the neurologic stuff and the mental health. I was trying to deconflict all that stuff and like tease it out a little bit. And as soon as Aaron, you were talking about like the mental health piece and then the cognitive stuff, like at least I'm trying with this to get some like clarity about what's going on with this. We have 40% of you voted. Let's wait another 10 seconds or so. All right, let's see the results on this. And for whatever reason, I missed adding the pulmonary one, which is really critical to add. And so my bad, okay? All right, let's stop there. Everybody had a chance to see that. And the next one, now I got pulmonary on there. Okay, so this one, it's got similar responses, except for I got the pulmonary on that one. But this is what has the worst impact on outcomes. There we go, 50% voted. Let's see the results on this one. Pulmonary by far. And then you got the neurologic in a second. All right, everybody's had a chance to see those. Let's do the next one. The next three are like straightforward. They're not like, a board's question. These are pretty straightforward. In your healthcare organization, which of the following PPE supplies are you most short of today? Ever since the beginning of the pandemic, we've been tracking this on rounds over time. And It's been fascinating to watch early on. Well, I'm not going to say, I don't want to bias these. Stop. Uh, 50% of you voted. Thanks for voting, really appreciate it. And it looks like N95s. Wow. Bruce, I don't think we've seen that high for N95s in a while. I know we haven't. That's actually really helpful information. As all of you are aware who've been on rails before, we share this information here internally at HHS. As you're seeing it, they get to see it too. And this kind of information helps inform everyone. Next. Since January 1st, 2021, I have seen new patterns of disease in some COVID patients. For those of you that haven't voted yet, if I'm encouraging to like jump on this one because it's an important one in terms of us doing some peer-to-peer learning here and seeing what's going on. I'll wait another like 5 seconds on this one and then we'll stop. All right, let's go ahead and stop. And for those of you who hadn't been weren't on last week's rounds when I did this same poll, the first time I did the poll, which I think was last Monday, the percent was either 37 or 38% said yes, and then indicated yes. And then the next one we did, it was 30%. So this is the third time we're at 30% or above. Makes me wonder if there's something there. All right, thank you. And then the last one. This is all about the vaccine and you personally. And by the way, these are all de-identified. We don't like link these to your individual thing, you know, et cetera, et cetera. So, and we've asked this question on multiple occasions just to see how things are tracking with our healthcare workforce being vaccinated. And after this is the last one, then I'll go around to Harry. I see Ed has joined us. If he's got any comment, questions, always welcome. And then to our speakers for any last word. All right, let's stop there. 53% voted. Thanks very much, everybody who participated in the polling. And this the 51% who received the first and second dose, congratulations. It's actually tracked upward just as I would have hoped it would have. And I think that's pretty consistent with what we've seen in recent polls. I didn't do any vaccination polls last week, I don't think, but the week before it's pretty consistent. there's a little bit more, I think, compared to what we saw recently in terms of those not being sure about being vaccinated with 11%. But yeah, thanks very much, everyone. I appreciate your participation in the polls. It's an opportunity to all learn from each other. Thank you. All right, so let's see. Harry, any last question, comment for the group?
Just a last comment. First, I want to thank the two presenters for this, because this has been really on the forefront of my mind, and applaud you for taking this aggressive stance to move forward while we're really in the middle of taking care of people in the pandemic. You haven't lost sight of this picture of what's coming, because I think in a way that will be our second pandemic of all the post-COVID complications and need of care. And taking this kind of stance, I think, is going to give us an ability to maybe get ahead of that, and perhaps allow institutions like yours to really shoulder some of the burden of deciding how we're going to deal with this post-COVID syndrome. But thank you for all your time and your upfront version of how things are working through your institutions there.
Yeah, thanks, Harry. Ed, I know you've been able to join us. If any question or comment, briefly introduce yourself and go for it. If not,
Yeah.
fine.
Thanks, Rick. Yeah, Ed Michelson, Texas Tech, El Paso. I'm looking forward to watching the video of this. Hopefully it'll be up later this afternoon, because you're right, I was unable to participate in most of it. But I'm curious to see how we're all going to deal with the long-term downstream consequences of this pandemic. We've been so busy just trying to keep our heads above water and handling patients as they come to us. Now that things are starting to slow down a little, I hope it stays that way, and not clear what the future holds, but we'll do our best.
And every time I think about this, like I put it in the context of, okay, there was September 11th, and think about the congressional testimony on survivors from that within the past year and a half. And then there's this. Yeah, wow. Okay, so Aaron and then Alba. Aaron, anything for the good of the group before we end? Questions, comments?
Yeah, just maybe a little, bird's eye view. I think in some ways this pandemic is allowing us to think about delivery of care to these complicated patients in another way, and also to think about other types of outcomes early on in the discussion of various medical conditions. I think really looking at quality of life and return to life and function, and including those in our discussions of outcomes of all types of patients is really, I think this is a unique opportunity for that.
Thanks, appreciate that, Aaron. And part of, as the two of you have been talking about, thinking in the back of my mind, okay, so what is it, and this is like the delivery, the model of care for this. Is it the super, and UW and Hopkins is super centers, okay. Is it you go with super centers, large tertiary care centers, and make that centers, or do you really distribute this much further? In particular for this, trying to figure that out, that whole model, what's going to be the most effective for so many people? And I don't know what the answer is, but we're figuring it out. Alba, any last word from you? The mute thing.
There we go. Just thinking about what you were just talking, we believe that part of our job is to identify the patterns of the natural history of the disease, right? And how we can identify these patients and how we can make it simple for later. But at this time, there's, the reality is that there is a need and it needs to be provided now, right? And I think one thing that I always like to share whenever I speak about the PAC clinic is the importance of recognizing post-COVID syndrome, of recognizing that this is something that patients can be quite disabling, and that there are physicians out there that we're trying to help them reintegrate to life. So, and the other fact is that, people that had mild disease can also be suffering this. And, you know, a lot of our patients find us 6 months after they've been, you know, not unable to finish school, unable to, you know, on FMLA, or not even getting paid because they're unable to do their job anymore. So it's just spreading the word that this is a real, you know, conglomerate of symptoms, and these patients do need to have their needs met.
Yeah, thank you. Bruce, before I like do the thank yous, any comments that you might have around this topic would be welcome.
Just really appreciate what Alba and Aaron are doing, sort of leading the way, as many others are going to be following and building on the experience you're already accumulating. I think in terms of that issue of how to scale up, I think there are going to be a variety of ways, one of which could be classic teleecho, which is creating virtual, you know, training primary care providers and you know, bringing the multi-specialty consult team to them so they can then, you know, really serve their patients within their FQHC networks and other community-based networks. And anyway, I see a lot of opportunity for collaborating possibly on the academic medical center based centers of excellence and these, you know, more community-based initiatives. So I think we'll be talking about this more in the future.
Yeah, it seems like if ever there was a time for distributed learning really fast, and much like, you know, I have learned from you as participants over the past week that maybe this new clinical pattern thing, you know, 30% or over 3 times, that, you know, okay. So same with the concepts that you're like really breaking ground on. What's working and what's not is going to be really, really valuable in the future. With that, I think, Bruce, did you have another comment before I ended? Yeah.
No, lots, but for later.
Yeah, lots. Yeah, lots more to talk about. Everybody's got to get to whatever the next meeting is, or whatever next clinic schedule, patient, whatever. But thanks to our participants. Really appreciate the your active participation in the polling and the chat and the questions, which makes this learning platform as valuable as it is. And to our panelists, thanks for joining. Harry, you know, wear a coat. I mean, seriously, it's too cold down there. And I don't know if it's cold down there where you are, but golly, I mean, I'm looking at what those weather reports, it's just extraordinary. And that Aaron and Alba, really appreciate your like jumping in. And yes, it's another to do these presentations, but we're trying to put on the radar screens that are going to screen issues that are really, really important, not just in the future, but right now. And thanks for forging the ground. So with that, thanks to Echo for all your extraordinary support, and we'll see you on the next one. Bye.
My pleasure.
Bye.
Thanks.
Bye.
Thank you.